Good day, everyone. I am Richan Salazar together with my groupmates Samantha Andre Mendoza and Marinel O'Malley, here to delve deeper into a topic that is both intriguing and sensitive: bodies recovered from water due to drowning or immersion. Trigger warning: this presentation contains sensitive content and includes potentially distressing photos. Hence, viewer discretion is advised. The topics to be discussed for this presentation are the following. First, we have drowning, which includes the stages of drowning: freshwater versus saltwater drowning, near drowning, cold shock, and cold water immersion. Next, we have autopsy findings, which covers the role of autopsy, early post-mortem changes and signs of immersion, and incident rate and reports of drowning. And lastly, we have unconfirmed tests for drowning, which covers diatoms, post-mortem electrolytes, sphenoid sinus fluid, aortic intimal staining, and drowning index. To start our presentation, let us first tackle the definition of drowning. Drowning is an asphyxia due to partial or complete submersion of the body in a liquid, resulting in liquid inhalation, impairment of pulmonary exchanges, and oxygen deprivation. Drowning is a term used to describe a life threatening condition that occurs when an individual's airway is compromised due to partial or complete submersion of their body in a liquid, typically water. And this submersion can lead to several critical consequences, one of which is asphyxia. Asphyxia is a condition in which the body is deprived of oxygen, either due to a lack of air or an inability to breathe properly. When someone is submerged in water, their airway can become black, making it difficult or impossible to breathe, ultimately leading to asphyxia. Next is liquid inhalation. Drowning often involves the inhalation of the liquid in which the individual is submerged. In the case of water, this means the person inhales water into their lungs. The presence of liquid in the airways is a critical aspect of drowning and can result in severe respiratory distress. Next is the impairment of pulmonary exchanges. The respiratory system's ability to exchange oxygen and carbon dioxide within the lungs is severely compromised during drowning. Inhaling water can disrupt the natural exchange of gases in the alveoli, which is the tiny air sacs in the lungs, impairing the body's ability to oxygenate the blood. And lastly, we have oxygen deprivation. Because of the interruption in the oxygen supply to the body, a person who is drowning experiences oxygen deprivation. This can lead to hypoxia, which is a condition in which there is insufficient oxygen in the body to sustain normal bodily functions. And if untreated, it can result in severe injury or even death. Now, there are two instances in which drowning should be considered as a possible cause of death. First, when the body is recovered from a body of water, on the banks of a body of water, or near a fluid filled container, and if a body is found with head submerged in fluid. There are five stages of drowning. The first stage is the surprise or reflective inspiration. This typically lasts for a few seconds. During this stage, the victim recognizes the imminent risk and instinctively takes a deep breath to fill the lungs with as much air as possible. This reflexive action is an attempt to prepare for potential submersion. Next stage is apnea. This lasts for less than a minute, and in this stage, the victim, now submerged in water, holds their breath in an attempt to prevent water from entering the airways. The body initiates a natural response to protect the respiratory system. The third stage is the deep breathing or expiratory dyspnea. As the apnea phase continues, increasing hypoxia and hypercapnia stimulate the body's respiratory centers. This leads to expiratory dyspnea, which includes rapid swallowing and gasping for air. Unfortunately, this gasping allows water to enter the airway and gastrointestinal tract, exacerbating the situation. The fourth stage is convulsive. Due to the continued lack of oxygen, the brain experiences anoxia, resulting in bradycardia, arrhythmias, and convulsions. This stage is characterized by significant physiological distress as the body struggles to cope with the oxygen deficit. And lastly, terminal apnea or death. In this final and tragic stage, both breathing and circulation come to a complete halt. The victim experiences terminal apnea, which is the cessation of breathing and the heart ceases to pump blood. This stage represents the dire consequence of prolonged oxygen deprivation and marks the endpoint of the drowning process. Now let us differentiate freshwater drowning and saltwater drowning. Drowning can occur in various aquatic environments, and the type of water involved can have different effects on the body. Freshwater drowning and saltwater drowning differ in terms of their physiological effects, potential complications, and treatment considerations. For the water composition, in freshwater drowning, the victim is submerged in bodies of water with a low salt content, such as lakes, rivers, or pools, while in saltwater drowning, it occurs when the victim is submerged in seawater, which has a high salt content. For the effects on physiology, fresh water is less dense than bodily fluids. When fresh water enters the airways, it dilutes the electrolytes in the body, leading to a condition known as dilutional hyponatremia. This can cause cells to swell, leading to complications. Salt water is more hypertonic, which means it has a higher salt concentration than bodily fluids. And when salt water enters the airways, it can draw fluids out of the body cells, leading to hypernatremia and severe dehydration. For the symptoms and complications, victims of freshwater drowning may experience symptoms like coughing, chest pain, and pulmonary edema. Complications can include electrolyte imbalances, respiratory distress, and neurological issues. Saltwater drowning can lead to symptoms such as extreme thirst, frothy, pink tinged sputum, and severe pulmonary edema. Complications may include electrolyte imbalances, dehydration, and a higher risk of infections due to the presence of microorganisms in seawater. For the treatment considerations, treatment for freshwater drowning involves addressing electrolyte imbalances, providing respiratory support, and managing any complications. In some cases, diuretics may be used to eliminate excess fluids, while the treatment of saltwater drowning also focuses on managing electrolyte imbalances and respiratory distress. Rehydration is also a critical part of the treatment, along with addressing potential infections. And lastly, for the prognosis for freshwater drowning depends on the extent of hypoxia and complications. With prompt and effective intervention, victims may recover, but severe cases can lead to long term health issues or fatalities. Saltwater drowning can be more challenging to treat due to the unique physiological effects of salt water on the body. The prognosis varies depending on the duration of submersion, the victim's overall health, and the quality of medical care provided. Near drowning refers to a critical and life threatening situation where an individual has experienced submersion in water but manages to survive, either with or without medical intervention. Even though the person survives the immediate drowning event, they are at risk of various complications and medical issues due to the period of oxygen deprivation during the submersion. Survival following asphyxia due to submersion depends on several factors, including the duration of submersion, the quality of medical care received, and the individual's overall health. Survivors of near drowning are at risk of various complications, which may include pneumonia, pulmonary edema, hemoglobinuria, cardiac arrhythmia, fever, sepsis, sequelae of cerebral hypoxia, and cerebral edema. One of the most critical complications is the development of cerebral edema, which is the swelling of the brain due to increased intracranial pressure. Rapidly developing cerebral edema is a common mechanism of death in near drowning cases. As the brain swells, it can compress vital structures and lead to severe neurological impairment or fatalities. The cold shock response is a natural physiological reaction that occurs when an individual is suddenly exposed to cold water, leading to a rapid cooling of the skin. This response is characterized by a series of involuntary physiological changes designed to cope with the shock of the cold water. It includes the following key features. First, peripheral vasoconstriction. When the skin is exposed to cold water, blood vessels near the skin surface constrict or narrow. This vasoconstriction is a protective response aimed at reducing blood flow to the extremities to conserve core body heat. The narrowing of these blood vessels helps to limit heat loss through the skin. Next, hypertension. Cold shock often leads to a sudden increase in blood pressure known as hypertension. This response is a result of the body's attempt to maintain blood flow to vital organs such as the brain and the heart, despite the peripheral vasoconstriction. Third, inspiratory gasping. Exposure to cold water can trigger an immediate and involuntary gasping response. This gasp is an instinctive, deep inhalation of air and it can be quite forceful. It serves to increase oxygen intake, preparing the body for potential breath holding or gasping that may occur if the head goes underwater. Fourth, hyperventilation. Following the gasp, cold shock may induce hyperventilation, which is rapid and shallow breathing. This hyperventilation helps to compensate for the gasping and maintain oxygen levels. It can be accompanied by a sense of breathlessness or inability to catch one's breath. Fifth, swimming inability. Due to the physiological responses of cold shock, individuals may experience a temporary loss of coordination, muscle control, and swimming ability. This can make it challenging to move efficiently in the cold water and may increase the risk of drowning, particularly in open water. And lastly, liquid aspiration. During cold shock, there is a risk of involuntary swallowing or aspiration of water, which can lead to a risk of drowning. The gasping and hyperventilation can increase the likelihood of water entering the airways.
For the continuation of our discussion, I am Marinal Umali and I will be discussing cold water immersion. Cold water immersion. In cold water, the responses that act as precursors to drowning are evoked by skin cooling or cold shock, then cooling of superficial nerves and muscle in the limbs, and finally cooling of deep body tissue or hypothermia. Complications arise based on the body temperature. First is superficial tissue cooling. After the skin has been exposed to cold water, the next tissues to cool are superficial nerves and muscles. Those in the arms are particularly susceptible due to surface area to mass ratio of the arms and the relatively superficial anatomical location of nerves and muscles. Low muscle temperature can affect chemical and physical processes at the cellular level. This includes metabolic rate, enzymatic activity, calcium and acetylcholine release, and diffusion rate, and serious elastic components of connective tissues. At muscle temperatures below 25 degrees Celsius, fatigue occurs because cooling impairs superficial muscle fibers, leaving a smaller number of fibers to produce the same force. Maximum dynamic strength, power, jumping and sprinting performance have been related to muscle temperature with reductions ranging from 4 to 6% per degree fall in muscle temperature down to 30 degrees Celsius. While at nerve temperatures below 20 degrees Celsius, nerve conduction is slowed and action potential amplitude is decreased. Ulnar nerve conduction velocity falls by 15 meters per second per 10 degrees Celsius decrease of local temperature. Nerve block may occur at a local temperature of between 5 and 15 degrees Celsius for 1 to 15 minutes and lead to dysfunction that is equivalent to a peripheral paralysis. Next is deep tissue cooling or hypothermia. When we say hypothermia, it is core temperature below 35 degrees Celsius or 95 degrees Fahrenheit. Hypothermia affects cellular metabolism, blood flow, and neural function. In severe hypothermia, the patient will be deeply unconscious. The decreased oxygen requirement of cold cells and organs cause decreased respiratory and heart rates. This make it difficult to detect vital signs in the field. Tendon reflexes are absent and the pupils dilated. This may give the appearance of death. With regard to drowning, the most significant consequence of hypothermia is the loss of consciousness with deep body cooling. This prevents individuals from undertaking physical activity to maintain a clear airway. Body temperature below 35 degrees Celsius could lead to confusion, disorientation, and decreased muscle coordination. Body temperature below 33 degrees Celsius leads to hypoventilation, bradycardia, and irregular breathing. For body temperature below 30 degrees Celsius leads to stupor or unconsciousness and coma. Below 28 degrees Celsius leads to ventricular fibrillation. And below body temperature below 25 degrees Celsius leads to cardiac arrest and death. Autopsy findings in drowning cases can vary depending on several factors, including circumstances of the drowning, the time the body was submerged, and the individual's health condition. Autopsy plays a crucial role in cases of drowning by helping to identify potentially suspicious issues and thereby diminish or exclude the risk of undetected crime or homicide, to document injuries present and other relevant findings to permit accurate interpretation, including by others at a later stage if required, to determine the medical cause of death, to identify contributory factors if it's drowning, to identify non-drowning causes of death in bodies retrieved from water, and to assist with identification, particularly in case of prolonged immersion with decomposition or mutilation. There are signs that may support a conclusion of drowning include froth or plume around the mouth and nostrils from aspirated liquid mixed with air and pulmonary surfactant, sometimes referred to as a champignon de mousse. This may have been washed away and may be transient, but it's seen in other circumstances such as coma from sedative drug intoxication or severe cardiac failure. Frothy fluid in airways, which may also contain extrinsic materials such as silt, weeds, or sand, over distend lungs, sometimes to the extent that they are seen to overlap when the chest is open. They may be heavy, but a normal lung weight does not exclude drowning. Watery fluid and debris in stomach suggest immersion during life but does not confirm drowning. Other signs previously described of very limited value and not exclusive to drowning include pleural fluid accumulation, usually in saltwater drowning, middle ear or mastoid congestion and hemorrhage or asphyxia, hemolytic staining of the endothelium of the aorta, and carotids, which will also occur with decomposition. The most important sign of freshwater drowning in the lung is the occurrence of a dry pulmonary emphysema, the so-called emphysema aquosum. Increased phlegm production and foam formation create a valve mechanism by expiratorily closing the airways, resulting in hyperinflation of the lungs. These mechanisms create the image of ballooned lungs, filling the pleural cavities and reaching over the pericardium with their edges. Imprints of the ribs on the lung surface can often be seen. Histologically, the overinflated lungs present flattened and ruptured intraalveolar septa surrounding blister alveolar cavities. In addition, anemic and normally perfused areas alternate in the lungs while the alveolo-capillary membrane is damaged. The intensity of this injury is proportional to the duration of the drowning process. Early postmortem changes and signs of immersion. The findings are influenced by a multitude of factors that include duration of immersion, water temperature, and whether water was saltwater or freshwater, still or flowing water, or clean or polluted. Immersion modifies most changes observed after death. If the individual has drowned, typically the body will initially submerge and assume what has been called the drowning position. This is where the anterior aspect of the individual faces the bottom of the body of the water, and extremities and head hang downward toward the bottom while the individual's back is toward the surface. In shallow water, the hands, knees, dorsal aspect of the feet, and the forehead may drag along the bottom, creating post-mortem cutaneous abrasions that may be difficult to differentiate from ante-mortem injuries. These abrasions will be exaggerated in a strong current. As putrefaction progresses and gases are formed from bacterial activity, the body will typically surface unless entangled or the buoyancy is altered by clotting or personal effects. In a strong current or rough sea state, the remains may strike rocks or brush with enough force to create the appearance of significant external trauma to the body. Typical post-mortem changes combined with mud and debris as well as lapping of the skin of the hands and feet are typical for bodies recovered from water. Drowning victims frequently have fluid collections in pleural cavities at autopsy regardless of the post-mortem interval, while some of the pleural fluid may represent true effusion occurring as part of the drowning process. Fluid accumulation in the pleural spaces is commonly present in bodies recovered from water that have undergone decomposition irrespective of the cause of death. A similar phenomenon is seen with the presence of dirt and vegetation in the respiratory tract. Some aspiration of foreign material may occur during the drowning process, though water and debris may also enter the respiratory tree in the post-mortem period, particularly in turbulent water. Compared to non-decomposed bodies recovered from water, bodies that have undergone decomposition and recovered from water have been found to have increased pleural fluid accumulation, increased animal predation, and more commonly have dirt and vegetation in the lower respiratory tract. Rigor mortis and livor mortis are typically present in bodies recovered from the water, though the onset and waning of these classic postmortem changes may be altered by water temperature, current, changing of body position due to movement, and level of activity prior to death. Pink discoloration of the teeth and gums, an observation once thought to be a sign of drowning, is likely due to lividity in these tissues occurring while the body is in aforementioned drowning position. Perhaps the most well-known external change that immersion in liquid has on the body is wrinkling of the skin, particularly involving the hands and feet. Traditionally, this has been called washerwoman's hand or washerwoman's changes, though a better designation on the autopsy report will be the cutaneous changes of immersion. Cutis anserina, or goose flesh, is another cutaneous change of immersion and is caused by rigor of the erector pili muscles within the skin. Both of these changes, wrinkling and cutis anserina, will occur as a post-mortem change and do not require the individual to be alive upon entering the water. The usual post-mortem change of vascular marbling, dark discoloration of skin and tissues, bloating, and putrefaction occur in the water as they do on land, though at a different rate, particularly in cold water. Sloughing of the skin, particularly involving the hands and feet, is common with prolonged immersion. Accident is common with regard to body of water involved the proportion involving a bathtub was extremely high in Japan, which is 65%, followed by Canada 11%, and the USA 11%. Of the 13,634 drowning deaths involved bathtubs in Japan between 2009 and 2011, 12,038 or 88% were older adults aged 65 years old or above. While the percentage involving a swimming pool was high in USA, 18%, Australia 13%, and New Zealand 7%. Lastly, the proportion involving natural water was high in Finland 93%, Panama 87%, and Lithuania 85%. After considering the completeness of the report and quality of classifying drowning deaths across countries, to sum it up, drowning is a high-priority public health problem in Eastern Europe, Central Asia, Japan, which is older adults involving bathtubs, and the USA involving swimming pools. Psychotropic drugs and alcohol may contribute to fatal unintentional drownings. Alcohol is well-known risk factor of unintentional drownings, whereas psychotropic drugs like alcohol may cause psychomotor impairment and affect cognition. Drowning is one of the world's leading causes of unintentional deaths. Many studies in high-income countries have documented the association between drowning and alcohol, especially among adult males. By affecting the central nervous system and cognitive processes, alcohol may, for instance, cause a person to fall into water or to operate a boat in high-risk situations. In addition, it can also hamper the ability to swim and reduce survival in water. Also, intentional drowning or suicides have been reported. Drowning is the third leading cause of unintentional injury death worldwide, accounting for 7% of all injury related deaths. A South Korean study revealed 74.2% of drowning cases admitted to emergency departments between 1998 and 2011 had drowned themselves intentionally, with the intentional drowning cases ranging on the age of 25 to 49 years old, significantly older than those who had drowned unintentionally, ranging from 19 to 35 years old. A Swedish study over the period of 1992 to 2009 reported 31% of all drowning deaths in the country were identified as suicidal, with a significantly higher proportion in females and the highest incidence in those aged 50 to 59 and 60 to 69 years old. Homicide of a child by drowning occurs occasionally, but is much rarer than an adult is murdered in this way. When a victim is a child, there will be often be few or no signs of violence due to a difference in the size between the assailant and the victim. Unlike the evidence of a struggle that is often found in adult victims of homicidal drowning, unless the victim has incapacitated by alcohol, drugs, or physical weakness, or was unexpectedly pushed into or dragged underwater. The incidence of this case, in which the manner of death is undetermined in high in bodies retrieved from water. Therefore, a thorough investigation of such case is needed. For the undetermined is still one of the most common manners of death. Water-related deaths often are prematurely and at times subconsciously labeled as accidental drownings. While this is often the case, the presumption that a body recovered from within or near a body of water is an accidental drowning can hinder timely recognition of indicators of foul play and other important clues present in or around the death scene. This in turn may ultimately lead to false conclusions regarding cause and manner of death and adverse adjudication. Furthermore, failure to recognize certain scene attributes the bodily findings and suggestive of homicide can hamper further investigation, including interviews with the witness, and persons of interest or apprehension of suspect. The investigation of deaths associated with natural bodies of water can be particularly challenging due to the characteristics inherent in an environment that are constantly changing, such as in lakes, rivers, and oceans. It's also important to recognize that not all water related deaths can be presumed to be drowning, and other factors such as water and weather, temperature extremes, drug intoxication, or other natural diseases may be sufficient enough to be the cause of death and otherwise preclude drowning.
Good afternoon, everyone. I am Samantha Andrea Mendoza, and I will be going to discuss the last topic of our report, which is the unconfirmed test for drowning. The diatom test. Diatoms are microscopic unicellular algae that have a silica shell that is resistant to acids, heat, or body decomposition. They live in colonies, grow in abundance in fresh and salt waters, and their skeletons are widespread in soils. They belong to a class of more than 300 kinds and 1,000 species. The diatom test is based on the principle that diatoms can be detected in the organs of drowned victims if they aspirated diatom rich water into the lung before death. Diatoms can be used to determine a lethal drowning, that if a valid cardiorespiratory activity occurs, Diatoms reach the lung with massive liquid inhalation and disseminate via the bloodstream into organs. Diatom analysis includes water sampling from the site of corpse retrieval, tissue sampling under sterile conditions at autopsy, the brain, lungs, liver, and kidney, acid or enzymatic tissue destruction to collect diatoms and specimen analysis. The typical feature of diatoms, which makes it forensically important, is that their hard silica wall, which is acid resistant, and when the biological sample, the femur bone from the drowned victim, is taken for diatom examination using concentrated nitric acid, all the planktons engulfed from water in drowning cases are destroyed except diatoms because of their wall made up of hard silica. A criteria for a positive test is based on qualitative and quantitative diatom identification. Analysis may be considered positive if 20 diatoms are identified per 100 microliter of a pellet sediment extracted from a 2-gram lung sample. And for other close organs such as brain, liver, kidney, and bone marrow, more than 5 complete diatoms per 100 microliter of a pellet sediment extracted from a 2-gram tissue sample with the exclusion of fragments are required for confirmation of water inhalation. The water samples are collected according to a strict protocol. Two samples of 100 ml of water, each containing diatoms sampled by scraping stones found in adjacent water, are collected in clean containers at the site where the body was found or where the immersion is believed to have occurred. All reagents in glass containers must be assessed for the presence of contamination by diatoms and diatom free water used to prepare reagents. Contamination from exogenous diatoms can occur during autopsy itself by contact with algae attached to the clothes and skin of the victim. So, the method of sampling needs strict protocols to avoid contamination by diatoms at the steps of the analysis. Although the diatom test is a valid test to support the diagnosis of drowning, some authors have suggested the possibility of false positive diatoms. The test cannot be used reliably to establish the diagnosis of drowning when the immersion water contains few or no diatoms, which is the case as urban water systems, which are generally low in diatoms. Drowning in bathtub, for example, may not register any diatoms in the samples. Sphenoid sinus fluid. In cases of drowning, the presence of sphenoid sinus fluid is a nonspecific autopsy finding. However, studies have reported that fluid accumulation in the paranasal sinuses is more commonly observed in drowning victims. Free liquid in the sphenoid sinuses may be considered a vital reaction in drowning, non putrefied cases, and an indicator of drowning in immersed bodies changed by decomposition. Therefore, accurate sphenoid sinus fluid sampling is an important aspect of an autopsy in suspected drowning cases. Radiological imaging is widely used in forensic medicine worldwide. Among them, postmortem computed tomography or PMCT has the advantage of non-invasive detection of paranasal sinus fluid, bronchospasm, and body hemodulation in water. As a method, fluid volume in the sphenoid sinus was measured using a graduated syringe during autopsy, and a three-dimensional workstation based on PMCT images was used for the purpose of comparison. In putrefied bodies recovered from water, an amount of 0.55 ml of free liquid in the sphenoid sinuses may imply that the victim was alive upon their contact with their water. However, the presence of free liquid in the sphenoid sinuses does not necessarily indicate that drowning had been the cause of death. Aortic intimal staining. Freshwater drowning brings about hemodilution and hemolysis, which in turn stains the intima of the aortic root. Hemodilution caused by drowning causes red cell lysis, which further stains the intima of the aorta. Differential hemolytic staining of the intima of the pulmonary artery and aortic root may be useful at autopsies on bodies recovered from water. Recognized as hemoglobin imbibitions of the intima due to hyposmolar homeolysis. Both aorta and pulmonary roots were examined for intimal staining by washing them under running tap water and later drying with cotton. So the factors influencing the different intensity of intimal staining in the aortic intima, which is the hemodilution in the left ventricle, More dilution of blood in the left ventricle leads to excessive destruction of RBCs. Hemodilution depends upon both the struggle period, which is the amount of water swallowed, and the time for which the body present in water after death. So the water enters the lung because of hydrostatic pressure. Second is the postmortem interval. So after the body is recovered from water, the decomposition sets in fast and causes hemolysis. Hence, more the PMI, intimal staining will be marked. Thus, postmortem interval also plays an important role in the intensity of aortic root intimal staining. So, when the staining is seen in pulmonary trunk or when seen in both vessels but more intensely in pulmonary trunk, this could be attributed to hemolysis associated with decomposition. But when the staining is seen in aortic trunk or when seen in both vessels but more intensely in aortic trunk, this could be attributed to hemolysis associated with freshwater drowning. Thus, this differential staining pattern of the great vessels, when demonstrated correctly at autopsy, can be used to attribute the cause of death to freshwater drowning. So it was on the basis of presumed hemodilution of blood returning to the left side of the heart that Gettler's chloride test was formulated. This test predicted that hemodilution of blood in the left side of the heart in freshwater drowning would significantly lower plasma chloride levels, with saltwater drowning having the opposite effect. However, although these changes occur, this test has been shown to be neither useful nor reliable in confirming the diagnosis of drowning as Getter proposed due to the marked biochemical fluxes that follow death. That is, individual and circumstantial variability are such that there is no consistency in results. Application of the drowning index to actual drowning cases. The investigation of a drowning death involves both careful evaluation of the circumstances surrounding the death, including eyewitness testimony, and thorough autopsy procedure. Circumstantial evidence is considered crucial in such cases because the autopsy findings classically associated with drowning often lack sensitivity and specificity. Drowning is diagnosed by observing the autopsy findings based on water aspiration as a vital reaction. Externally, the presence of foam at the mouth or nostrils or both is important. This foam presents as a small balloon or mushroom like mass with a white or pinkish color. Internally, foam is also observed in the airway. Rather large pleural hemorrhage produced by tearing of the interalveolar partitions are sometimes seen, especially immediately beneath the pleurae. The lungs are bulkier ballooned, often to a degree which causes them to overlap the pericardium. Lung weight is sometimes increased, and pleural effusion is important in a longer postmortem interval. A lighter spleen weight with pulmonary findings is also useful to diagnose drowning. So, these findings, such as marked amounts of frothy fluid in the airways, increased lung weight, water in the stomach, hemorrhage of mastoid air cells in the middle ear, increased fluid volume in the maxillary and sphenoid sinuses, diatoms in the vasculature, hemolytic staining of the aortic intima, especially in freshwater drownings, and decreased splenic weight have each been associated with drowning but are poorly reproducible and may only prove that the body was submerged in water. So, a new concept in diagnosing drowning based on autopsy findings is the drowning index. It was devised to diagnose drowning deaths, which is the weight ratio of the lungs and pleural effusion to the spleen. A statistical analysis revealed that the total weight was heavier, while spleen weight was lighter, and the DA was significantly larger in the drowning group. The DA is considered very reasonable and useful to diagnose drowning. However, the diagnostic standard or the cutoff value of DI and the limit of the applicable postmortem duration have not yet been clarified. To apply the drowning index for diagnosis within 2 weeks postmortem, DI 14.1 is proposed as the standard DI value. Drowning is still a difficult autopsy diagnosis, but according to the study, DI over 14.1 is a valuable indicator. The key takeaways of our report. First is drowning. Asphyxia due to partial or complete submersion of the body in a liquid, resulting in liquid inhalation, impairment of pulmonary exchanges, and oxygen deprivation. The stages of drowning: first is surprise or reflective inspiration, second is apnea, third is deep breathing or expiratory dyspnea, fourth is convulsive, fifth is terminal apnea or death, and next is autopsy findings. Drowning is a diagnosis of exclusion based on ruling out all other causes of death via complete autopsy and toxicology. May see bloody froth in the airway, water in the stomach, cerebral edema or petrous or mastoid hemorrhage, lung overinflation or emphysema aquosum, wrinkling of the skin, particularly involving the hands and feet, or formerly called washerwoman changes, that develops when submerged in water for several hours, occurs regardless of whether the person died in the water. Postmortem lacerations or abrasions due to scraping along rough surfaces in the water or animal activity should not be confused with antemortem trauma. And last is the unconfirmed test for drowning. First, the diatom test. Second is sphenoid sinus fluid. Third is aortic intimal staining. And fourth is the application of drowning index. So that would be all for our report, and thank you for listening.